Once somebody sees PT as PCP for musculoskeletal needs, and you're the first point of encounter versus anyone else in the medical model, that's where you see that the true innovation, that someone is less likely to pursue other medical services for the same problem when PT is the first point of contact. Good morning, friends and colleagues, and welcome to the seventh episode of Future Thinking PT. It is great to be here, and I want to welcome my co-host and my dear friend, Dana Strauss. And today we're going to discuss a couple of really interesting things. The first thing that Dana is going to discuss is the team model that is emerging. So all the intricacies of this uh, really innovative, interesting model that will become much more prevalent in the next 12 months. And then we're going to go a little bit deeper into the weeds of PT as PCP using a military model. So both the validation, the safety profile, and some of the references that are being present. So without any further ado, Dana, I will hand the microphone off to you, and you can run us through this really cool model that's emerging.
Great. Thank you. Love to be back. Episode 7. Woohoo. We're making progress every week. So for anybody who's not familiar with the team model, the transforming episode accountability model, it is about acute episodes of care, and it is based on the original and the subsequent bundle payment for care improvement and the advanced model, as well as the comprehensive care for joint replacement model. Both of those models, these are Medicare fee-for-service models, were based on 90-day episodes of care after the hospital. So you're discharged from the hospital is day 1, it goes all the way to day 90. And essentially what the model says is everyone is going to bill normally for patient care starting when they're in the hospital bills normally. Everyone who has any interaction with that patient and bills Medicare is going to bill normally. Nothing changes about how they're reimbursed across those 90 days. But then when Medicare looks back every 6 months, they look back at the episodes of care during that time period. They reconcile the difference between how each individual patient did during that time. They look at their quality metrics, they look at their utilization, they look at their total spend, and they compare to a benchmarked cost and quality factors. They'll have what they call a target price. Whoever is the participant in the model, in some cases it was the hospital, in some cases it was the specific physician, that individual would either earn additional dollars because the spending was less, or would have to pay back CMS additional dollars because that individual spent more than was expected. And so if you can kind of imagine some of the things that would make someone cost more than expected, that would be things like higher than expected utilization of post-acute care, readmissions. If you manage care better than was done historically by being very careful about where you're selecting and working with the patient and the family on where they go after the hospital, when you keep patients mobilized when they're admitted to the hospital, when you help with the transitions of care to make sure they're all happening safely, and there's a lot of opportunity to do better here. All of those things can help you do better in many cases. So if you can have 2/3 of cases, for example, do better than historical, better than expected, you're going to end up making money in the program. In the team model, they took all these lessons they've been learning through these episodic models, and they started off now with a mandatory surgical episodes of care model with 5 different diagnostic groups. And for those patients are going to be hospital being at risk for the episode, and then looking at the spend and the outcomes for 30 days after. And what Medicare had said, our plan is to turn this into a model of care for virtually all Medicare beneficiaries who are admitted for an acute care stay. And it is mandatory for about a quarter of the hospitals in the country. It's around 40 hospitals total. And what Medicare did was they said, okay, we're going to take all the CBSAs, so these are core-based statistical areas, parts of the country, and then we're going to take all the hospitals in that area and all the hospitals in the chosen CBSAs, random, so they picked random CBSAs, they're all going to be included. Surgeons in one geographic area can't say, well, I don't want to do this, so I'm just going to go to the other hospital down the road that's not participating. Every hospital is participating in the area. So Again, these mandated participants have to be in this model for 5 years. They cannot exit the model voluntarily. So that's essentially how the model works.
The biggest question, I guess, for you would be that the model itself is designed on a more of a macroeconomic scale. So these are more of a hospital path dependence and trying to control the variables that result immediately following surgical care. How do you suspect that this model is going to impact clinicians, especially our target audience, down the stream? So how is it going to impact musculoskeletal spend immediately following surgery, 3 months after surgery, 6 months after surgery?
I think one of the reasons, as a physical therapist myself and having managed prior models that were longer episodes of care, I see tremendous opportunity, especially for outpatient therapy practices. And why there is so much opportunity is hospitals generally are sending too many patients to inpatient post-acute care, partly because they think they're unsafe to go home. A lot of the unsafe comes from reasons that precluded why they were admitted to begin with. And we're not optimizing who can actually be discharged home. In the original models, we were working on reducing discharge to skilled nursing, to inpatient rehab facilities, the ones that weren't medically necessary. We want patients to go where they should be going next. But there's a lot of discharge to post-acute inpatient settings that doesn't need to be happening. It's not medically necessary, and it's being done under the guise of safety if we kept patients moving in the hospital as best as possible, unless there's a contraindication. And we prepare from the day they're admitted, or if it's a planned surgery, we plan how exactly we're going to discharge them home. Then many, many more patients can be discharged home with either outpatient PT in the home, sometimes home health, and sometimes even directly to outpatient PT. Again, depending on what the specific surgery is. Those kinds of changes make the most material difference in the success of the episode. Every time you go to an inpatient site of care, you're adding an additional transition, 2 additional transitions of care. So going into, let's say it's a SNF, discharge from hospital to SNF is a transition. There's so much that can and does go wrong in that transition. Then there's the inpatient stay, and all of the things we know can happen during an inpatient stay that are not desirable. And then there's the transition back home. Sometimes it's a transition to another post-acute setting. So we want to minimize transitions. We want to get patients home where they can be mobilized right away. We want to train patients and their families. We're trying to shift spending to outpatient settings so that people are back in the community, back in their own home environment. And who is best to help those patients make the right transition and become mobilized again and function, but therapists. And so in this model, the CMS actually calls out team participants contracting with outpatient PT facilities as a partner in this program. And I think every outpatient PT OT should be thinking about how they can be proposing support to their hospitals, not just ways to access therapy easily, quickly, have a great transition home, but how they're going to help them make sure they get back to see their physician. How can they help them with protocol for discharge? Because therapists are ideally situated to help hospitals think about what happens outside the hospital more.
Let's spend a little bit of time clarifying. So there's the way I see it, there's 3 variables that we should really discuss. The first variable is the actual transition point, like who is the gatekeeper for this transitional periods. So who actually controls the phase transition from hospital to skilled nursing facility and or home health. The second part to control is that the decision for each landing spot, at least superficially, is based on the critical level and the risk, right? So that skilled nursing facility is the hierarchy of highest level of clinical triage, followed by home health, which is the intermediate level of the triage, and then home-based or outpatient facilities. Who is responsible for the stratification, and is there an algorithm that is at play? And the second point is that the landing spot itself, are the landing spots prepared for this level of volume that potentially they're going to see. So are the outpatient in-home facilities prepared to provide services that will directly fit into the team model? And have we learned any lessons from previous models that we can provide right now to the participants?
They're good questions, and I'm going to start from the bottom up. First, the episodes selected are just in 5 diagnostic groups, so it's not covering anywhere near the volume that was covered in the BPCIA program. So they started with surgical episodes because CMS had the evidence of success of surgical episodes before they saw the success of the medical episodes. And so that leads us to believe, as long as things go as they have been, that they'll add in more of those episodes after. And then let's go to your first question on transitions, who decides? In my experience in working with many hospitals in this and speaking to a lot of therapists, a lot of rehab directors about this, essentially what ends up driving the discharge disposition is a decision that's made far too late. And what typically drives the decision is therapists' documentation. It's shocking how often I would see this. Patient unsafe, discharge to SNF. What does that even mean? And when you really have to peel back the layers of the onion, as much as I don't like that cliche, it's really applicable here. And what it ends up boiling seriously down to is therapists, and they have gotten this feedback over time that it's easiest to discharge patients to SNF because the people who are leading and marketing at the SNFs come right in, they paint a beautiful picture of skilled nursing, and they do 95% of the work to get that discharge completed. So it's a positive feedback loop that feeds anybody who potentially could go to SNF goes to SNF. Discharging to home health requires a lot more work on the part of staff, right? They have to make sure the prescriptions are called in. They have to make sure they have follow-up appointments. They have to make sure home health is going to be able to be there within 48 hours. But there's a lot more work, and then they worry that patients are going to be unsafe. But the preparation to help them become safe is not necessarily done. And others that, potentially could impact like the success or the complications have not been addressed. So great example, someone with a new colostomy bag. Right? In order to be able to go home, you have to teach the patient and the family what to look for a wound infection to make sure they know how to empty the colostomy bag. The nurse will be out the next day. Therapist will be there as well. They don't have to know more than that. But in the vast majority of cases, if there's any indication that they can go to SNF, they punt them to the skilled nursing facility and think that the skilled nursing facility will teach them the colostomy care. Again, in my experience, that doesn't happen either. They end up holding them for a long time in the SNF because they haven't taught them the colostomy care, right? So there's all of these things that can be done better in the hospital that aren't done better because there's no incentive to do better. The hospital's paid one lump payment based on the diagnosis, covers everything. It doesn't matter if they send them to skilled nursing or home health, or if they teach them or don't, or if they train the family or don't. It doesn't matter. Literally doesn't matter financially. Yes, there's quality metrics there around the edges, but for the most part, they're not incentivized to make sure patients get home. Part of it is, I think, that they're okay with it, is they don't realize the damage that can come from people going to sites of care when they don't need to be there. And that's a story for another day. And then you had one other question about the decision-making and stratification. Yeah, most of that honestly is boiling down to what I just said about therapist documentation. The physicians, the social workers or discharge planners, nurses, whatever, will look at the documentation. They say PT said go to SNF, they send them to SNF. And that's about as far as it goes.
It's really interesting. So there's a couple of things to unpack here too, and one of them is that ambiguity of the transition formula. There's just no one source of truth for the readiness for the transitioning. The second part is that friction points, right? So you have, I think what SNF figured out is if they reduce the transition friction point, they're going to have a higher volume of patients matriculating into their domain because like they take care of all the hard parts, they take care of the paperwork. All you have to do is just show up, right? Now, the last question I think, then, for you is What happens when it's a non-hospital entity that performs this procedure? Do they apply to the same rules if it's in outpatient surgical center, or if it's in the outpatient non-surgical surgical modality, right? And that do they follow the same team's model, or do they then not apply?
There are inpatient procedures that are allowed to be done on an outpatient basis. Those will also be triggered. So if you have an outpatient total knee replacement, that will trigger the episode in the same way. You remove in that situation, you're going to remove the possibility of someone going to skilled nursing because they need the 3 overnights in order to qualify to go to skilled nursing. But one thing I'd like to put out there for any acute care therapists who are listening to this, or who are working an outpatient and have a good relationship with acute care hospital therapists, one of the biggest barriers I touched on is the lack of mobility that is standard in a hospital stay. I've had experience with hospitals who literally have every person on bed rest only removed if the physician goes into the chart and removes bed rest. So no link between medical necessity of bed rest and actual bed rest. Now, unstable fractures, right? An active blood clot. There are, of course, reasons why a small percentage of those admitted to the hospital medically need to be on bed rest. We take these people coming in, walking, even if they're using a walker, they're coming in with some illness, and they leave up to completely dependent or have lost a large percentage of their strength, balance, and safety because the hospital allowed them to lay in bed the whole time. I mean, it is an atrocity. There are hospitals who have owned doing better in this because they just knew they had to do better. And they institute robust mobility programs. CMS has run programs where they try to work with hospitals across the country. There have been many initiatives. Johns Hopkins has done a lot of work around this, and many hospitals have, but it is still more common than not for patients to enter mobile and exit immobile for no medically necessary reason whatsoever. So if acute care therapists want to demonstrate proactively how their department can create something to help solve for one of the big levers of the team model, so they at least don't lose money in the downside risk of the model and potentially earn more, help create and structure a mobility program with specific parameters around how, when, who, where, why, that typically is monitored by, created by, overseen sometimes by the therapy department, but is really a nursing program, right? It's CNAs that in the past ran mobility programs. It can be, physical therapy aides that can do it as well. But the whole point is, if we now create an incentive for hospitals to mobilize patients, and if that's the only thing that was accomplished in these episodic models, it would be monumental, right? It's so much better for people. And this is the kind of reason I get so excited about value-based care models. We're just changing the reasons you should care. Sometimes you have to bring these opportunities to hospitals to say, can we create a program? Here's the ROI, here's the cost, right?
So there's the two things here is the size effect, like the fact that the small changes lead to big consequences. There's also the nice repository of old laws that have never been changed, and we just continue to practice them. Like in Alabama, it's illegal to wear a fake mustache to church, so it is readily practiced. Or in with Alaska, it's illegal to get intoxicated in a bar. If you think about it, it's a law that probably has outlived itself, but we continue to enforce it. The same goes with some of these arbitrary healthcare laws that continue to be practiced because no one either questioned them or no one looked into changing them. And now we're beginning to change them. So hopefully this will result in a much better, much more robust tidal wave of change on the healthcare community as a whole. Looking forward to it, and hopefully this CMS is going to do a good job keeping track of data, so we can then really have a much more granular appreciation of some of these principles. Awesome.
This is a great example of the success of the Innovation Center. There's, if you follow this stuff, there's a lot of criticism that the Innovation Center models don't save money. There's a whole lot of reasons for why it can look that way, the way the evaluations are done. Topic for another day, but the episodic models are so powerful because they're one of basically two ways you can change the incentives for acute care hospitals. One is make them responsible for what happens after. And then the other is global budget model, meaning we're paying hospitals based on historical claims. They're not being paid for their Medicare patients normally. They're not billing as they normally would. Again, creating the incentive to only admit patients that really need to be admitted and to prevent readmissions. So we have global budgets and then we have episodes of care. Those are the two, right now, the two ways we change incentives to hospitals. ACOs have a harder time doing that. I am a big fan of episodic models. Not all ACO supporters feel the same way. I do. I'm sort of have a contrarian viewpoint, but it comes from having so much direct experience trying to change behavior of hospitals. So I think we should stop there on team so we can cover the other super cool topic for the day. The military model of primary care PT has gone back for decades and has been shown to be very successful. It has not translated into the layman community. So what we wanted to touch on today, I'm even going to bring up a visual here while Alex chats about this, is what is this military primary care model? What's it about? Why has it been working? And what can and should we learn from it as we talk about these issues around value in primary care, PT, et cetera?
Appreciate it. And I think if you look into the biggest argument, there are really four criteria that have always been used as a pushback for physical therapists practicing direct access. And even in a country with 50 states having some laws governing direct access to physical therapy care, we still have yet to fully optimize direct care utilization because it's just not the model that is being advertised to the clinical community. An emergence of clinicians choosing to practice direct access first. But the pushback has always been on four variables. And the first variable is that effectiveness of physical therapists as a direct access primary care musculoskeletal practitioner. The second point is the safety profile. Are PTs safe to provide primary care musculoskeletal care? The third point is that operational efficiency. Can we do it in an efficient way where we don't overutilize? And then the fourth point is there any documented record of PT as a MSK PCP leading to a lower downstream effects, essentially being preventative towards a later downstream healthcare problems and crises. And so now, considering all this and considering that a private sector has really been pushing back against some of these laws, we do not need to look any further than a U.S. Military model. So the military model has been keeping track of these four exact parameters since 1974. And so if you look into that, both the qualitative and quantitative data to prove all of the four variables, it is readily available. So if you look into that effectiveness of management, PT as PCP, on the five the most likely diagnoses for physical therapy needs, PT has proven to be highly effective. We can do a really good job both screening and providing care for traditional musculoskeletal problems. So then we move into the second domain, which is the safety profile. Are we safe to both screen, triage, and provide care for the musculoskeletal problems? And once again, you can reference military data that PTs are not just safe, they're highly effective at ruling in and ruling out some of the red flags, being able to triage clinical services to the right discipline when that need comes, and also being able to provide qualitative care for the right diagnoses. So then we look into the third domain, which is the cost effectiveness. And this has been, again, studied on a federal level, studied on a commercial level. I mean, we referenced this in the prior episodes that we're cheap. For good and for bad, PTs are just cheap compared to the rest of the healthcare community. We are cost effective if you look at the global cost of care, but also if you look at the local cost of care. So whether you receive 10 episodes or 12 episodes or 20 episodes of care on a global scheme, we're still incredibly affordable compared to some of the other healthcare modalities. So definitely cost effective. And the last is that the holistic or the preventative model. Once somebody sees PT as PCP for musculoskeletal needs, and you're the first point of encounter versus anyone else in the medical model, that's where you see that the true innovation that someone is less likely to pursue other medical services for the same problem when PT is the first point of contact. And again, we look into the military model, which uses PTs as PCPs, but then translating it to a commercial space, when you use APT as a first point of contact, you just don't spend as much downstream and you have better clinical effects. People just don't pursue other medical services because they're able to take care of self, adding to agency, adding to efficiency. I think that the biggest overarching theme is that we don't need to look for references to justify PT as a PCP for musculoskeletal problems. We have it available through the military model. We have close to 50 years of robust data to support it on those four primary domains.
At first glance, what I say to myself is, first, what the heck? If this is so obvious, there's so much clear evidence of the effectiveness and the safety and the cost effectiveness and the benefits to patients and access. So we chatted about this briefly as we were prepping. Maybe you can talk a little bit about the incentives in the military, why the incentives are different, and those have driven some of the acceptance and adoption of PTs as one of the PCP members of the PCP team.
Yeah, absolutely. And I think you have a clear picture of incentives in the military because each recruit, each member of the military has a specific numeric value assigned to him or her as an agent. And the military's primary focus is the readiness and a health of that individual and their ability to perform their duties. So when you take away all of the contextual nuance, the primary responsibility is to optimize the function of this unit, this individual. And depending on a rank, depending on the duties of that individual, there is a monetary value associated with that individual for the length of care. And this is me just using arbitrary generic values. But if a cost of human life for the duration of military service is $3 million, you would want to protect your asset by investing into that asset's well-being, right? So that if you want to protect the human being able to perform optimally, and you will also invest. When you take away from the emotional contextual nuance, all it is if I have a military vehicle that I've paid $2 million for, I don't mind spending $100,000 for yearly maintenance because it still is cheaper than replacing the vehicle downstream. When you have a human health associated with future performance, I don't mind investing in PT as PCP because I know there is a clinical outcome profile that is well established. So I'm going to cut away from all the noise and create a PT as a primary point of contact for some of these really redundant clinical conditions. And we have an exemplary model that has been in existence for all this time that if only our commercial payers recognized that then there would be that dramatic transition, should be a dramatic transition to PT being mandated as a primary point of contact, but not in a perverse incentive that just go fail your PT before you can go get your shots and get your surgery. It's going to be go succeed with PT. And then if you don't succeed, that's when other services are going to be available to you. So I think if you look into the overall net value of PT as PCP, again, looking from the numbers from the US military, it is well established clinical efficacy for that model being practiced that is just not being endorsed or embraced by a commercial sector in the United States and hopefully will in the future.
And I'm going to translate that a little further to say the incentives in the military are not billing incentives. There's no physician that is earning more because they're doing more fee for service visits, right? The objective in the military is so that everyone who has chosen to be part of the military is able to continue to perform their duties and succeed and be part of the unit and preserve their value. And so the military is incentivized to find the best, most cost effective, and most appropriate intervention at the most appropriate time. There is no competing culture or incentive to do more of other things that cost more. Contrast that starkly to the norm and the culture in a fee-for-service environment. If the norm is for back pain, you see your PCP and then they send you to ortho, where you go right to ortho and they do imaging and yada, yada, yada. Well, the payer has to pay for those things, and some things will get prior authorization, and prior auth is one of the things therapists don't like, and most providers don't like. But again, that a lot has to do with just the incentives for the provider to do more and more. We are still not mainstream as their PCP is. We are someone our ortho sends us to. And that is purely a cultural issue. And there's been no reason for physicians to promote us being seen first, because it impacts their own billing. If they see fewer low back pain patients, and physicians have the strength of the voice. So just that it is such a completely stark difference. We have all this wonderful evidence on the military side, but we have a capitalist, fee for service program that rewards volume.
Right.
Yeah.
Yeah, so I think that there's really three things that we need to look into, that really I think are the primary barriers for this model being adopted.
Mm.
And the first barrier is the scope of practice. We just have a amazingly low level of understanding of what the scope of practice is for a physical therapist or occupational therapist or any allied health scientist or clinician in United States. Clinicians that are practicing don't understand what their rules or regulations are around their practice. They may understand the rudimentary Medicare rules, they may understand the rudimentary ethical rules, but very few clinicians actually do a deep dive into a appreciation of what the scope of practice, what their liberties are. We just choose to entrench ourselves into this very narrow scope of practice, partially because we don't invest enough time to understanding it, and we just get indoctrinated into, I'm a PT, I'm just going to continue to go through this safe lane because I have been doing it for years and not venture out anywhere out of it, right? But the reality is we actually have a pretty broad scope of practice in the United States, and depending on the region, like there's 26 states that have unlimited direct access. We can do so much more already within the parameters that have been set up for us. The second, I think, constraint, or the second limitation is a collaborative issue. We continue to go into the entrenched practice modalities. We don't collaborate, which we need to collaborate with other healthcare practitioners. Now, it's same surgeon that may have a perverse financial incentive to do a lot of surgery. In reality, like there's no limitations for surgery. Most surgeons are busy enough as it is. Most of them will have a 6-month wait, especially the good ones, right? So they're not starving for surgical cases. Good surgeons will provide surgery when surgery is needed. Good surgeons are the ones that are feeding all the PT clinics anyways, because they're the ones that are sending out. And only, what, 3% of all MSK cases that are triaged by surgeon actually result in surgical care. So that's 97% overflow towards non-surgical care. That's 97% of overflow where, if you are in a collaborative mindset, you build your community of professionals
Hmm.
and you work with surgeons in the same level because you are a musculoskeletal professional, you're a physical therapist, provide non-surgical care. But that's the key, is building a community of collaboration, and we just don't collaborate. And the third parameter is understanding the regulatory p- allow us to practice. As you were saying, that creating friction points between a patient being seen, creating prior authorization, which prior authorization, for in case people didn't know, is nothing more than a payer's way of creating a friction point to deter further utilization. There's no other reason for it except that it's a deterrent. It's the same reason why you hopefully will have a deterrent that based on the price point from eating too much ice cream, right? Like it's like too much ice cream will result in a health detriment. So maybe there's going to be a deterrent that charge $2 more for ice cream, or cigarettes, right? Cigarette tax is a financial deterrent from smoking that has worked, where you make cigarettes past a certain threshold, past the price point, and people are going to smoke less because it's the tipping point of not wanting to spend. So understanding the regulatory parameters and regulatory deterrents, but also being able to work with them, is the key. So that's like those are the three things that we need to figure out, is that understanding the scope of practice, being able to collaborate with the larger medical community, and understanding the legalities, the regulatory parameters around our practice so that we can function on a higher level.
Think it might be helpful to hear about what does it actually look like in the military when someone has a complaint, an injury, and they have to determine if they should be seeing the PT first. Unless you've been in the military, you haven't had direct experience, but can you just talk a little bit about what that looks like right now? What is someone working in the military, what is it like for them when they have an injury and they need to get treatment? How does that communication happen? How do they determine where the patient goes?
Yeah, so again, not in the military, so definitely would be helpful to actually have like a Dan Roan or a Jason Silversnail on, because these are the guys that are actually so involved and so doing such an amazing job steering the military complex into this higher level of practice. I think that the time that it takes for the PT referral, the time for the triage is one of the data points that is being tracked. So you just have an immediate onset of PT triage following a musculoskeletal complaint. The days on a profile, so that you're tracking the overall length of clinical encounter. And then the number of actual visits are being tracked. So you see that you want a quick emergence of clinical triage. You want a shorter duration, and you want visits that are necessary, right? But I think definitely understanding that PTs in a military model act like PCPs. If you have a musculoskeletal complaint, you don't have to go through the traditional cycle. PT is going to be the person that's going to take care of you. So if you come in with a complaint that is classified as a traditional musculoskeletal complaint, you don't go through the typical cycles of a federal system or commercial system. You go through a cycle of, it's going to be a physical therapist that takes care of you, and that physical therapist will decide whether you get imaging, whether you get pushed further down a healthcare model where you do see a specialist, or you stay with a physical therapist and receive care. So that these are the things that, like, once you use PT as a PCP, that PT becomes a point that triages care down the stream farther, based on what their clinical opinion is, what exactly. So these are exactly perfect points, what their future needs will be. So it's a way of both ruling in and ruling out other further clinical necessity based on need, based on the availability of resources, that eliminates all of the noise, eliminates all of the other ancillary low value care.
I love it. I think about the role of team-based care, and it's an inevitability. We're going to move more towards team-based care. And I think about what physicians love about working in team-based care, the ones that are fully entrenched in it and have the incentives aligned. So it makes complete sense for them, both for their own, uh, professional enjoyment and satisfaction, but also because it makes the most sense financially. And doesn't it just make so much more sense for, someone who has no red flags or any other reason why they should see the PCP first, that since we have the therapist right there, where if we have the therapist do the evaluation, you're going to open up the physician's ability to offer more access to patients with medical needs that can and should be seen by a physician or a nurse practitioner or PA. Some of them are going to probably need PT as well, but we're addressing access to care with foundational facts, things like we know low back pain and shoulder pain and osteoarthritis pain and gait disturbances and balance problems are super common reasons why folks are showing up at their PCP's office. The PCPs don't have a lot of tools in their toolbox to address a lot of these issues. They can give them medications, it's education, it's referrals, it's imaging. But what else? This is an interaction that has to be ongoing to address a lot of these problems and to sustain and improve those patients over time. So I love that this is just best for everyone involved. And the military has already given us a playbook of how to do it right and be successful at it. And it's not that it's 5 years old. This goes back decades, right? Decades. This is long
Systematic,
established.
yeah. I would even venture to say that there is such an immense opportunity for the younger clinicians right now that are going through this existential crisis, right? Like 5 years, 6 years out of school. Do I want to stay in physical therapy? Is this the right setting for me? Again, to reference, we're losing 10% of our workforce to attrition because people are just looking for an exit, for a non-clinical exit. The clinician that is most ready to fit this new model of advanced care are these young clinicians that have still a fresh understanding of the clinical complexity. They have fresh awareness of being able to rule in and rule out some of these nuanced clinical flags. And they have the absolute need to elevate their level of practice instead of just being burnt out and leaving altogether. So it's almost a call for young clinicians to elevate their level of practice based on what they were trained to do. Now, if they have finished physical therapy school, if they have finished their graduate training, they have the capacity to elevate their level of practice. I definitely would advocate for residency training or fellowship training because there is, again, evidence that shows that someone who finishes a residency, someone who gets a board certification in orthopedic or sports or geriatric physical therapy will be able to provide a higher level of triage, higher confidence in triage. And so think of this as an opportunity to not don't leave clinical care, but instead change your setting, change your mindset, and actually elevate your practice. Examine your state regulations and state rules and elevate your practice. Maybe go off on your own and start your practice so that you can fit some of these emerging models. So you can be that team's triage for receiving care, right? So that you don't have to stay within these PT mills that just burn you out and chew you out and are only using your license, but you can elevate, you can self-advocate into a higher level of clinical practice. So my call to arms.
Gotta say one last, I was thinking about listening to a podcast on that you need to specialize, and that specialization is a driver of business success and professional success. And I'd say what came to me was we have to think about what a specialization look at broadly. It's not all or nothing. We want therapists who are experts in primary care, PTs, who that's their calling, is to be part of team-based care, to do triage and to see some patients regularly, but be a generalist. And then we have outpatient clinics that are going to have generalists and specialists in them, right? And then we're going to have therapy clinics that are doing solely things like pelvic health or MSK ultrasound. So all of those things need to be celebrated and supported, but without each of them having a stronghold in place, we can't give to the healthcare community what we are capable of giving, and we have the skills and knowledge and license to give, unless we have all those things in place and we have established ourselves as primary care team-based care providers, independent, although fully collaborative, outpatient multi-specialty clinics, and then individual specialty clinics. And all of those things need to thrive for a profession to thrive. I think we still aren't getting the message out fully either that the DPT, it's a post-bachelor's 3 full years of education. It is just shy of that 1 additional year of med school. Our level of education is so superior to, I think, what most of the medical community understands it to be. But we do need to be more outspoken. We owe it to the public because we could be giving so much more and adding so much more value to people's lives. I talk a lot about money, but it's only because it's value to lives that's completely aligned. We have to wrap it up, but if we could quickly just touch on the book that you wanted to bring up,
Absolutely.
Alex, and then we'll get
Yeah.
it wrapped up.
Just in one sentence, Dana, you're absolutely right. There's 270,000 well-qualified clinicians with advanced clinical training that can take on this advanced task of actually working on top of their license. So a call to action is just examine where you are and examine your role and then see how you can be a better fit for the healthcare model. So the book, really a quick mention, Maria Konnikova, The Biggest Bluff, a brilliant method of applying, I guess, a acquired logic and acquired knowledge to a new skill set. Maria Konnikova has a PhD in psychology and has become a world-leading poker player. So I guess maybe that is a good reference where you have someone who has an applied knowledge to a new setting to become really highly successful. The book itself is much more nuanced into the human logic and human characteristics and how you can infer a lot of awareness to and pay attention to human behavior as a way of actually becoming highly successful in your setting. Being aware of the complexity of human behavior, but also being aware of the complexity of these systems and how these systems apply to our rudimentary function is the key. So Maria Konnikova, The Biggest Bluff, check it out. It will definitely add value to you on just a global life thing. So yeah. And Dana, this has been great. This has been such a wonderful conversation. I think there's so much to learn. Hopefully that our community is able to look at this video, read some of the newsletters and become a little bit more aware. So thank you for this. And thank you for informing clinicians about this emerging model.
Thank you. And this is a fabulous breakdown of what we know, not being military PTs, of the military model. We're in episode 7 and we're really enjoying ourselves, getting some nice feedback. We want to be able to bring on guests. There's several therapists I can think of off the top of my head that would be amazing to chat with us if they're interested. So I guess we'll leave it at that for now. Talked again today about the team model, more to come, and about the military model of primary care and PT and how we can translate the lessons that we have learned and the benefits of it into, regular life outside the military. Thanks, everybody. You're the best, Alex.
If you enjoyed the show today, please subscribe to the channel and hit the like button and come back for more next week. Thanks again.